Ankur Institute of Child Health, and he was the HOD of GCS Medical College. Emni Kirti beyond India જાય છે. He is also the president of Pediatric Association of SARC in 2005 to 2008. If we look at his publications and awards, it will be endless. Nonetheless, published more than 100 articles in journals and books. Welcome, sir.
Good morning, friends. It's indeed a great pleasure delivering the first talk on this extravaganza Guj Pedicon at Surat. We all know the hospitality of Surat friends, and since yesterday, we are enjoying that hospitality. Thank you so much for inviting me to be one of the guest faculty for this very important conference. Well, friends, we all know last 3 months or so, we had outbreaks of various viral diseases, started from the vector-borne disease like dengue, chikungunya, and few cases of malaria, and then respiratory illnesses. We all know that respiratory illnesses are the commonest cause of outdoor practice as well as indoor practice, especially in pediatric segment. And probably it is around the year that we get different type of illnesses. So today I'll be talking about the commonest viral illnesses, how do we diagnose them, and how do we manage them. Well, in the past, when we did not have many vaccines, that time, whenever there were infections, we were thinking of bacterial illnesses. But now, with the availability of different vaccines, the scenario has changed. And world over, the protocols have also changed. In Western world, which is a evidence-based medicine, whenever there was a case of PUO with some viral illness, they were thinking that probably it is a streptococcal infection or pneumococcal infection, and they had advised that, especially in children less than 3 years, to start with the penicillin or penicillin-related antibiotics. But now things have changed. Everywhere now thinking that probably as the viruses have taken care of all these different type of bacterial illnesses, so commonest is the viral, and that is why protocols have changed, and they have advised that one should give symptomatic treatment, try to find out the cause, and then only think of treating the bacterial illness. Let's see a few cases. The first one, a 6-year-old male child. These are all the real cases which I saw in last 3 months or so in my practice. The child had come with fever, high grade with chills for 5 days, cold and cough for 5 days, treated at other place with antibiotics, IV fluids. There was no improvement, and so brought to our hospital. When child was brought to us, temperature was 103, respiratory rate was 33, conjunctiva was red, there was presence of rhinitis, throat was congested, and respiratory system shows bilateral few crepes and bronchi both. Liver was 2 centimeter, spleen was not palpable. With this, we investigated, and the initial investigations, hemoglobin count, etc., was showing that probably it's not a bacterial one, though child was treated with antibiotics. And we thought that probably it is some kind of a respiratory viral illness, and we sent throat swab for the PCR. And this came influenza B virus, which was present there, and child responded to the antiviral treatment, and child was all right. The next case, a 2-month-old child had fever, excessive crying, cough, difficulty in feeding. Child was transferred from other hospital as there was no improvement. Again, child had fever, respiratory rate was 48, heart rate 124. Antifrontally were open but at level. Child was irritable and cranky. There was no pallor. Respiratory system did not show any findings, no crepes or rhonchi. It was a silent chest. The abdomen was distended, liver was 3 centimeters, spleen was just palpable. It was tympanic, but peristalsis was present and other systems were normal. Again, if you look at the investigations, the count was 3,550, plus polymorphs were 64, platelets were 1.2 lakh. X-ray chest was little hyperinflation, rest was normal. So again, we thought that this is some kind of a viral illness, and we sent throat swab to look at the viruses, and where as the season there were some cases of influenza also, so we asked for both, and this child had RSV infection. So again, second case was of viral illness, RSV virus. Third case, 8-year-old male child was transferred from other hospital. He had fever for 5 days, cough for 5 days, not able to stand since last 3 days, and there was a decreased oral intake. There was a oliguria, temperature was 100, rhinitis was there, mild, throat was clear, tenderness of both the thigh as well as calf muscles. CNS was more or less normal, little decreased tone in power in both the upper and lower limb. But child was not able to stand on his own, and other systems were normal. The primary investigations again were more suggesting on the lower side of total count with low polymorphs. Platelets were also low, so it was again season of the vector-borne disease, so we sent for NS1, which was negative, but CPK total was 1200. Chikungunya thought of, but it was also negative. And then we thought that look for the other viruses in the throat, and this came as influenza type A, H3N2 was positive. So again, this was one kind of respiratory virus illness, which has brought this child with a CNS type of symptoms also, along with very few symptoms of respiratory system. Another case, a 5-year-old male, a female child, had fever for 5 days, cough, dry, brassy, paroxysmal cough. There was a post-tussive vomiting also. Temperature was normal, respiratory rate 32, heart rate was 100, the SpO2 was normal. There were no other big positive findings. There were no Krebs or bronchi, and other systems were normal. Again here, the investigations were more suggestive of viral illness and was not contributing. We again sent for throat swab. COVID we thought first, and we sent for COVID, which was negative, but again this child had RSV positive. So even the child at age of 7 years had RSV virus, which was positive and causing the disease. Another case, a 4-year-old male child had fever mild to moderate since almost 40 days, and daily child was getting 2 to 3 peaks. History of cold cough in first 7 days of illness. No history of vomiting, pain in abdomen, body ache or joint pain. Temperature was 100, throat congested. Bilateral cervical glands were present. Biggest was 1.5 by 1 centimeter. Liver was just palpable, spleen 2 centimeters. So this was the condition, and child was getting fever almost for 40 days. The primary lab investigations, hemoglobin was 10.7, total count 8,120. Lymphocytes were 68. Platelets were 2.28. SGPT was 482, SGOT was 356, alkaline phosphatase 136. Vidal was negative, Brucella were negative. The cultures in the past sent twice were also negative. COVID antibodies, we thought that probably child is maybe having MISC, but COVID antibodies were also just borderline positive or equivocal. So then we thought that this is probably infectious mononucleus, and EBV capsid VCA was sent, which was more than 160. So this was a EBV virus infection leading to the prolonged fever with the lymphadenitis, plus there was a hepatosplenomegaly. So friends, we all know that in the past acute lower respiratory infections, we thought we all know that they can be bacterial as well as viral infections. The acute viral bronchiolitis and bacterial and viral bronchitis were remaining the leading cause of global child mortality for many years, especially in third world country. And with the newer steps that has been taken by governments all over world, the bacterial pneumonia has gone down considerably, and because of that, there is a now increased use of vaccines which has targeted these certain diseases, especially bacterial respiratory pathogens, and that has reduced. So now, world over, the leading cause of all acute lower respiratory infections are most of the places it is viral infections with RSV virus, influenza virus, parainfluenza virus, rhinovirus, and human metapneumovirus are the top viral conditions in children, and that leading to the different type of clinical presentation. So if you look at the commonest viruses that can cause viral illnesses nowadays, at present because of pandemic, COVID-19 may be the heading the list, but I am not going to talk about COVID-19 now today. I will be talking about the other viral infections, and other are the rhinovirus, coronavirus, common coronavirus, I mean, influenza, RSV, parainfluenza, adenovirus, EBV virus, human metapneumovirus, and human Boca virus. Out of that, rhinovirus, influenza, RSV, parainfluenza, and adeno, they are the commonest that can lead to different type of clinical presentation. The common cold is the commonest type of acute viral URI that we see day in and out, and about 50% of all colds are caused by one of the more than 100 serotypes of the rhinoviruses. The common coronaviruses, which are almost 4 different types, they can cause some outbreaks. The infections caused by influenza viruses, parainfluenza viruses, enteroviruses, adenoviruses, and RSV and metapneumoviruses can also cause the common cold-like symptoms only. And out of all the common cold viruses, in different studies, it has been found that in spite of the investigations by PCR as well as culture, 20% of the common cold is still by unrecognized viruses only. Out of all that we see, rhinovirus is probably commonest for causing the cold. And this occurs in certain seasons, fall and spring. They are most efficiently sprayed by direct person-to-person contact, although sprayed may also occur via large particle aerosols. The most potent deterrent to infection is the presence of specific neutralizing antibodies in the serum induced by the previous exposure. And susceptible, as there are many myths about the cold, that the children can be susceptible because by exposure to cold temperature, host health and nutrition, or upper respiratory anomalies, but these are the myths and not the true. It is the exposure to the virus which leads to the common cold rather than the exposure to cold or any other food or other related things. The common coronavirus, excepting the COVID corona, are 4 types which can lead to again different types of rhinitis and URI. These include types 229E, NL63, OC43, and HKU1. There are outbreaks of this type of virus causing the upper respiratory infection. They are usually mild to moderate URI and is the cause of about 20% of colds are because of this type of outbreaks. This is different than the coronavirus 2019, and it should not be confused with that virus. So even by the PCR of COVID-19, these viruses are not detected, so they are totally different viruses. Another common virus that can infect the human being is the influenza, and we all know that there are 2 types, type A and type B. Type A has many different combinations of H and A, and there is antigenic drift in H and NA antigen produces strains that cause a pandemic with significant mortality. It can cause fever, coryza, cough, headache, and malaise. And influenza itself may cause pneumonia, or patients with influenza may develop secondary bacterial pneumonia. So that is how there may be different issues with this. What happened to this slide? more we technically advance, there are more glitches and problems. So we have to have our foot down to the earth so as we don't face this type of. And influenza can be diagnosed by the now RT-PCR which are available, the reverse transcriptase PCR, which are sensitive and specific and can differentiate influenza types and subtypes. They can be also diagnosed by antigen test also, but the sensitivity is less. Most of the patients are treated symptomatically, hardly any need of antiviral drugs. The drugs which are used for as antiviral commonest is oseltamivir, but in some cases in Western world they may use zanamivir and peramivir. Recently a new drug has been launched in the Western world, which is a baloxavir, which has more efficacy and require short course of the antiviral drug. The antiviral drug is recommended only for high-risk patients or the patients which are hospitalized for some kind of the complication that a child develops. This recommendation is based on data suggesting that early treatment may prevent complications in these type of patients which are immunocompromised or those who are high-risk patients. The RSV infection is the next commonest infection that we see. Most of the children by 2 years of age can get infected by RSV infections, and children can affect even adults once they get the infections. Usually there is an annual outbreak in all age groups. Most healthy children and older children who get RSV will get a mild case with cold-like symptoms only, but some of the children who are younger than 1 year, especially younger than 6 months, can get a severe disease, and that can lead to commonest is the bronchiolitis, or sometimes we call it pneumonia also. It could be dangerous for some infants and young children, especially those who are born premature and who had some respiratory problems when they are born. They can have a very severe disease and can lead to a severe infection. Commonly used type of RSV clinical laboratory test for the diagnosis is the now RT-PCR, which is more sensitive than culture and antigen testing. In some situation, antigen testing can be used, which is sensitive in children but not sensitive in adults. So in younger child, even antigen testing can also help. There are no specific antiviral drugs which are used in most of the world, except in USA. They are using palivizumab, especially in a very young, high-risk infants like those who are born very small as a premature child, and there this drug is used, and there is a good result from within these conditions. The para-influenza virus is another virus that can cause the disease. There are 4 types of para-influenza viruses, 1, 2, 3, and 4. They share antigenic cross-reactivity. The common illness in children is URI again. Para-influenza type 1 is a frequent cause of croup, and so any child coming with croup, 99% they will have para-influenza virus. Para-influenza type 2 also can cause similarly croup, but it is a less severe. Para-influenza 3 can cause pneumonia and bronchiolitis, and para-influenza 4 has a mild illness. A specific viral diagnosis is clinically unnecessary, and it may help distinguishing para-influenza virus from a bacterial infection in some situations. Again, the treatment is a symptomatic treatment. No specific antiviral drug is available or needs to be given. The another virus which can lead to respiratory illness is adenovirus infection. The adenoviruses are classified according to 3 major capsid antigens like hexon, penton, and fiber. There are 7 human adenovirus species starting from A to G, and because of that there are 57 different type of serotypes of adenoviruses which can cause infections. The different serotypes are associated with different conditions. They are commonly acquired by contact with secretions from infected person or by contact with a contaminated object. Infection may be airborne or waterborne, and asymptomatic respiratory or GI infections which continues shedding the viruses, and because of that they can infect the other children or persons. In immunocompetent host, most adenovirus infections are asymptomatic and they are not recognized and they just pass, but they shed viruses and that can infect the other people. It can cause fever and URI-like symptoms, including pharyngitis, otitis media, cough. The picture may be like exudative tonsillitis with cervical adenopathy in many situations. And here we need to distinguish it from group A streptococcal pharyngitis. In the Western world, they differentiate it by the RDA, which is available there. Adenovirus type 3 and 7 can cause distinct syndrome of conjunctivitis, pharyngitis, and fever, which is known as pharyngoconjunctival fever. Rare adenoviral syndrome in infants includes severe bronchiolitis and pneumonia. Recently, Dr. Pallab Chatterjee from Kolkata had published a series of cases where different types of lower aspect infections were caused by adenoviruses. That is probably the biggest series that is published from India about the adenovirus infections. In close populations of young adults, it can cause outbreaks of respiratory symptoms like fever and URI. It could be either tracheobronchitis or occasionally pneumonia. The epidemic keratoconjunctivitis is sometimes severe and occurs sporadically, and it can damage the sclera and conjunctiva, cornea also. Non-respiratory adenoviral syndromes include hemorrhagic cystitis, diarrhea, and meningoencephalitis. Most patients recover fully. Even severe primary adenovirus pneumonia is non-fatal, excepting very rare fulminant cases. PCR testing can detect adenovirus and is useful when patients have a severe disease and diagnosis is needed, especially if the child is in ICU and child has some other immunocompromised situation. Treatment is supportive. There is no specific viruses which are antiviral treatment available. Another virus which can cause disease is the EBV virus. It is a human herpes virus 4, which is a gamma herpes virus. The primary infection is causing acute infectious mononucleus, which is characterized by fever, lymphadenopathy, hepatosplenomegaly, malaise, and abdominal discomfort. It is the first human virus confirmed to be oncovirus, and it can give rise to various lymphoproliferative malignancies, and some types of lymphoma can be caused by EBV. Again, there is no specific treatment available. The diagnosis is simply by total WC count, where you look at heterophile type of specific lymphocytes, and heterophile antibody test can be done, which can help. Normally in PS, if more than 20% atypical lymphocytes or more than 50% lymphocytes with at least 10% atypical lymphocytes, you can suspect the infectious mononucleosis. A positive result of antibody test is also strong evidence, and confirmatory testing can be done by capsid antigen VCA IgM, as in our case we did it, which was very high. The antibody response is like that. So if you are testing for the IgM VCA, in first 5 days probably it can come negative. So normally, if you are suspecting infectious mononucleosis, start testing after about 7 days or so, then there is a high chance that this will be positive and you can get the diagnosis. So friends, the diagnosis of viral respiratory infections is typically clinical evaluation and local epidemiology. We need specific tests in a very, very few situations and only in a complicated cases. The diagnostic testing is reserved for situations in which knowing the specific pathogen which can affect the clinical management. Or if you want to epidemiologically know what are the outbreaks due to, then for that type of epidemiological surveillance, you may ask for the specific diagnostic test. Otherwise, in most of the situation, it is a clinical condition and the situations can help you. The tests which are normally available and which can help in making the diagnosis, they are rapid antigen test, direct fluorescent antibody test, viral cultures, PCR, which can be standalone as well as multiplex PCR. The rapid point of care antigen-based diagnostic tests, they are readily available, but they are not that sensitive. That is why they are not routinely used. Direct immunofluorescence assays are rapid and inexpensive method. They are recommended for infants and children due to high sensitivity of these tests. But commonest tests which are done are the PCR tests. Cell culture or serological tests are slower than PCR tests, but may be useful for epidemiological surveillance. The cultures, they are observing the cytopathic effect, and that is how one can find. It is considered to be a gold standard. But the viruses like adenovirus, influenza, RSV, para-influenza are most common that are isolated and detected by cell culture. Now, modified cell culture methods which are used has reduced the turnaround time from 5 to 10 days to 24 hours. But despite these advantages, many clinical relevant viruses are difficult to grow in culture and may produce variable regions, and that is why viral culture is not still a commonly used method.
Sir, 1 minute
and not
remaining.
used. There are wide variety of newer nucleic acid amplification tests which are available, and these are very important. And nowadays they are considered to be a second gold standard for the diagnosis of the viruses. Single individual pathogen is suspected, then monoplex real-time PCR or combo PCR can be used. While these are different types of nets which are now done, there are large syndromic panels available now in the some of the tests, some of the labs, and which are very important. And studies have reported increased diagnostic yield more than 60%, and sensitivity is almost close to 80 to 100% with this type of the test. The one panel which is available commercially is the BioFire Respiratory Panel 2.1. It is a PCR-based multiplex nucleic acid test intended for use with BioFire field array or BioFire field array torch system. It allows healthcare providers to quickly identify common respiratory pathogens. Panel yields results in approximately 45 minutes using the narrow swabs. And these are the different viruses which can be identified. Another panel which is available is the pneumonia plus panel. Again, that is based on BioFire field array. 15 of the bacteria panel provides semi-quantitative results which may help determine whether an organism is a colonizer or a pathogen. Is more sensitive than culture. Difficult to grow organisms in culture can also be identified with this type of studies. The panel identified a bacteria in additional 22% of ball or sputum specimens, and that helps you in identifying the organisms. Samples that we required for this type of test are ball or sputum, and in performance, if you look, in the ball, the sensitivity is 96.2 and specificity 98, sputum 96.3 and specificity 97.2. These are the organisms which can be detected from these panels, and this is another group of bacteria which can be identified. Even the antimicrobial resistant type of the enzymes which can be also detected by this type of pneumonia plus panel. So friends, to summarize, majority acute viral infections in pediatric age group are viral in nature. In most situations, clinical evaluation and local epidemiology gives the diagnosis. You don't need a very specific diagnostic test. It should be typically reserved for situation in which knowing the specific pathogen can affect the clinical management. Monoplex PCR can help in diagnosis in majority situations. Multiplex PCR like BioFire is helpful in intensive care setting and immunocompromised situations. And low resource setups and third world countries, cost is the prohibitive factor. So as there is a biggest limitation of this test. Otherwise, they are very useful tests. Thank you so much, friends. If there is any question, it will be my pleasure to answer them.
Thank you, sir, for this wonderful session. I would now like to invite Dr. Rakesh Desai, sir, to felicitate Dr. Raju.
We shall be taking questions at the end of the session.
Moving to the next session, I would like to invite Dr. Nirmal Chorodia, sir, to present the topic of approach to upper airway emergencies. Dr. Nirmal Chorodia is the head of the department Nirmal Hospital and the director of the PICU. I welcome you, sir.
There is a small announcement. We are having a wonderful lecture over here. If anyone is interested, there is paper presentation going on at 6th floor cluster hall.
ये लेजर लाइट है
स्लाइड चेंज यहाँ से कर सकते हैं इधर से
एक बार कर दो स्लाइड चेंज
Good morning, everyone. First of all, I would like to thank Academy of Pediatrics Gujarat and organizer of this conference pact for giving me the opportunity to present